Hello, everybody. So my name is Anais, and I will give you a talk that is different from the one you've heard this morning. So I'm not a health person, not a clinician, physio, or anything. I am a scientist, and I'm a final year PhD student. So I'm Kiel University working in an orthopedic hospital, and I will present you identification of predictive marker to TNF inhibitors therapy in psoriatic arthritis. So just I will explain a bit about psoriatic arthritis, just for those who might not be familiar with them. So psoriatic arthritis is a heterogeneous chronic immune-mediated inflammatory disease, and it's characterized by many features, including psoriasis with a skin condition, dactylitis, so swelling of fingers and nail dystrophy, axial and peripheral arthritis, and also enthesitis. So what happened in the what happened for the pathogenesis? So in psoriatic arthritis, immune and adaptive cells infiltrate the sites of inflammation, and they secrete lots of mediators, inflammatory mediators, such as TNF alpha, interferon gamma, IL-6. And those mediators exacerbate the inflammation and contribute to the progression of the disease and to the inflammation in skin and in joints. So I'm not really sure how it works here in Poland, but in the UK, there is no curative treatment. And what happened is that patients is first treated with non-steroidal anti-inflammatory drugs, so ibuprofen, naproxen, then with conventional synthetic DMARDs, such as methotrexate, leflunomide, sulfasalazine. But if they do not respond to this conventional therapy, they can be prescribed a biologic drug. And TNF inhibitors is typically the first one prescribed for psoriatic arthritis. So in my study, all the patients were treated with adalimumab. So it's an engineered antibody, and it targets TNF alpha, so it exists in a soluble form and in a form that is bound to the immune cells. And by binding to TNF alpha, it prevents its binding to the receptors and the subsequent inflammation. However, around 30% of PSA patients do not respond to this treatment, and we need to find biomarker of response so we can prescribe the right medication in the first instance to the patients. And this is what we're doing with the Paris study, psoriatic arthritis resistance to TNF inhibitor study. So what happened for the study is that patient is consented at baseline. So the clinical team perform a PSARC exam to assess joints and health, global health of the patients. They also require blood tests for inflammation markers, such as ESR and CRP. And for the Paris study, I get an extra 20 ml of blood that I'm working on. And I review medical records for concomitant medications and for comorbidities. Then the patient receives his first injection of TNF inhibitors and is followed at 3 months and 6 months with the same routine care. So to monitor response to treatment, we use the PSARC score. So this score consists of a tender joint score, swollen joint score, and a physician's and patient's global health assessment. We can note an improvement if there is 30% reduction of the tender or swollen joint score, and if there is a reduction by 1 score of the global health assessment. And we can say that a patient is responding to the treatment if there is an improvement in one of the 4 items, one of which must be a joint count, and without worsening of any of the 4 criteria. So the aim of the overall study is to find a biomarker of response to TNF inhibitor in psoriatic arthritis. And the objective of this specific study was to look at clinical data, immune cell profiles, and proteomics. So when I started my PhD, it was COVID time. So I struggled recruiting patients, but I ended up recruiting 18 patients with psoriatic arthritis. So here you can see some demographics and clinical characteristics. So in average, my patients recruited in the study were 48 years old. 55% of them were male. you can see that in average, the BMI was 32.2, so the majority of the patients recruited were obese. We also have some information about treatments. So an important one is that 2 patients were not biologic naive before starting adalimumab. So we decided to remove them from the study to avoid adding more variabilities because we already started with a small cohort. And then you have some information on the scores. So I followed them and looked at the response at 3 months and 6 months, and we divided them into full responder, moderate responder, and non-responders. So full responder, they had a complete remission in the tender and swollen joints. Moderate responders, 30% response at least in both joint score, and non-responder at less than 30% improvement or worsening of the symptoms. You can see here the numbers of patients in each group, and it changes at 3 months and 6 months. Some patients responded really quickly and then stopped responding a few months after. Some of them took longer to respond and then stay in remission. And this is important because we will be able to classify our biomarker as a short-term or long-term biomarker. So first I looked at clinical biomarker. So all data is coming from electronic patient records. We've been looking at age, sex, BMI, inflammation marker level, smoking status, disease duration, and psoriasis, because not all PSA patients have psoriasis. We were also interested in comorbidity, but we have a small cohort, so instead of looking at individual comorbidities, we looked at it as a whole using the RDCI score. So it's a comorbidity index that is giving me a score ranging from 0 to 9, and it reflects the burden of the comorbidity to the patient. And so we decided to look at age, sex, smoking status, and BMI because they can influence drug metabolism, distribution, and response. We looked at comorbidity and disease duration because it can lead to contraindication of treatment prescription and polypharmacy can alter treatment efficacy. And we looked at inflammation marker because they can give us a signal like, is it a severe disease or not severe? And disease severity can influence response to treatment too. So this is a forest plot. I don't really know if you know how it works or not, but we have odds ratios on the x-axis. If the odds ratio is on the right, it means that a patient with a high level of this marker tend to be in a higher responder group. If the odds ratio is on the left, it means that patients who have a high level of this marker tend to be in a poor responder group. So at 3 months, we can see that patients with high level of inflammatory marker tend to be in a higher responder group. And we can see that patients who have a longer disease duration tend to be in a lower responder group. We can see that this trend is also present at 6 months. So patients with higher level of CRP, so one of the inflammatory markers, tend to be in a higher responder group. And interestingly, patients with more comorbidity, longer disease duration, and higher BMI all tend to be in a lower responder group. But so we didn't just look at the clinical marker. Then I'm collecting blood, and I've been looking in the blood. So when I receive a blood sample, I process it, and I collect plasma, the yellow band, and the white interface that contain all the immune cells. In this white interface, I'm looking at lymphoid cells, and I have a focus on natural killer cells and T cells. And in the T cells, I have a focus on T helper 1 to 17 cells and regulatory T cells. Sorry, I don't know if it means something for you or not. But and I'm also looking at myeloid cells and dendritic cells. So all of those cells, they secrete a lot of mediators, and they are all measured in the plasma. So regarding the cellular marker, we can see that patients with higher Th1 to Th17 ratio tend to be in a higher responder group. This was the only significant trend we have, but remember, we have a small cohort, so we can still see some trends. Patients with higher level of Th1 and regulatory T cells also tend to be in a higher responder group, and patients with higher level of monocytes, Th17, Th2, and Th17 and Treg ratio tend to be in a lower responder group. At 6 months, we lose this trend. As you can see, all the odd ratios are really close to 1, and we have a huge confidence interval. So this means that all the marker we can see here seems to be short-term marker, but not long-term marker. Then we look at the mediators in plasma. So at 3 months, you can see that patients who have a higher level of those markers, it doesn't really matter which one, all of them tend to be in a lower responder group. But we have some stronger trends, and patients with higher level of IL-1 beta, TNF alpha, IL-33, and IL-13 tend to be in a lower responder group. Here again, we lose the trend at 6 months, which is quite logical because the mediators come from the cells. And the only thing we can see is that patients with higher level of CCL2 tend to be in a lower responder group. So just to sum up all of this, because it's a lot, so those marker mediators secreted by the cells seems to play an important role. So IL-33, IL-1 beta, TNF alpha, and interferon gamma, they are all elevated in plasma of patients with psoriatic arthritis who are not responding to treatment. We know that inflammation markers are also elevated in patients with high BMI, long disease duration, and multi-comorbidities, and that patients with those clinical characteristics, so they have elevated marker, and elevated marker can also lead to this condition. We also saw before that monocytes was a predictor of poor response. Monocytes, they differentiated to macrophages, and both the cells secrete those markers. IL-33 play a role in the differentiation of Th17 and Th2 that was predictor of poor response. Th2 secretes IL-13, that was a predictor of poor response, and IL-13 inhibits Th1 differentiation, that was a marker of good response. So everything seems to be linked, like the pathway itself seems to predict response. But we will need to monitor regularly because we can see that it's only a short-term prediction and not a long-term prediction. And also, so it's a small cohort, so it will need to be validated in a bigger cohort. And maybe we will be able to find a cutoff to know at what limit the patients will respond or will not. We're planning to extend this work a bit. So we're planning to do a more regular monitoring of the marker. I did it with the 6 months sample for the cells already, but that's why it's not here yet. I need to go deeper in the analysis. We know that sometimes we can have some issues with plasma measurements. So protein can be dilated in plasma. They can be hidden by highly abundant proteins. They can have a really short half-life. And that's why from January, I will look at extracellular vesicles that I will isolate from the plasma samples, and it will give us more accurate data. I'm also planning to do some metabolomic study and explore the changes of the metabolite before and after treatment, and hopefully identify also metabolites predicting response to treatments. And once we will have all of this data, then hopefully we will be able to apply for a large funding and confirm all of this data in a larger cohort. And of course, I need to acknowledge the lab, my team, and my supervisor who helped me in this project.